I think I mentioned the Singapore model where actually I think in that case the government gives you an HSA and then you spend it. So it is a market force in a way because you're spending what feels like your own money. So that might be a sort of a purple way to view all of this. Use of market forces, but also helping those who don't have financial means. So next up, so we're going to change gears a little bit. So everybody's heard a lot about how important price transparency, competition, empowering at the front lines is, third parties are a problem. We're going to change gears a little bit and talk on the supply side. This afternoon, you're going to hear from Robert Grayboys a little bit about supply side as well as technology and healthcare. But the supply of physicians, and with telehealth, we've seen that now you can get healthcare online across state lines because of COVID. Regulations have been loosened about getting primary care from a physician who's not in your state. Normally that's not allowed. But Dr. Feldstein, who's speaking next, is going to help us think a little bit more broadly about innovating around medical licensure. And he also wrote a chapter in the book as well. So talking about how to increase the supply of providers, including primary care physicians. So Dr. Feldstein, thank you so much for speaking. By the way, everybody has incredible credentials. I didn't want to suck up the whole conference by reading their credentials. They're in the handout that I've given you. Dr. Feldstein has had a long, illustrious career, including at Mayo Clinic. He now happens to be a visiting fellow at the Goldwater Institute. So thank you, Dr. Feldstein. Hopefully we can make you live in a second here.
Can you hear me, Dan?
We can hear you now. Yes, it's all yours.
Can I get my video open?
Is there a way to get your?
I think so.
I think we saw you. There you are. We see you.
All right. Thank you. So we've been talking a lot about empowering patients, and I'm enough of a fly fisherman that I know what a wind knot is and a snarl. And I'd like to get to the first knot and then hope everything else unravels. As a practicing clinician with over 50 years in the trenches, I feel more certain than ever that we have to reform our antiquated system of medical licensure. No other proposal in front of you today has the potential to simultaneously increase availability, avoid rationing, improve quality, and maintain or even reduce the cost of healthcare. Because historically, our market for medical care was infected by the virus of medical licensing laws before any of the other symptoms of market malaise came about. And without eliminating that germ, the symptoms might change, but the disease will persist. Now, 21st century technology holds many promises, but they have trouble being realized, and they have already been delayed because of current licensing restrictions. Now, there are many ways this reform could be accomplished, but the most important thing to be done, the distilled essence of reform, is to depoliticize the process and try to get politicians out of it as much as possible. So the best way to demonstrate what I think I mean is through a couple of thought experiments. So in your mind, take us back to the year 2010, and you're in the middle of a rainstorm near Rockefeller Center in Midtown Manhattan, and you want to get downtown to the West Village. So you're standing in the street with your hand out, and you get splashed by taxis driving by with their occupied signs illuminated. After about 10 minutes, one stops. You open the back door, and some guy behind you jumps in, slams the door shut, and leaves you out in the street. That happened to me. Now, fast forward to today. The rain is worse, but you're inside a Starbucks finishing your cappuccino. You take out your smartphone and open up an Uber or a Lyft app, and a minute later, the vehicle pulls up to the curb, you saunter into it, say hello to your driver by name, and drive off. You know the fare before you start, and it's electronically paid when you exit the vehicle, and the tip is up to you. You can rate the driver, and the driver can rate you. Now let's switch to another scenario. You've just moved from one state to another and your driver's license is expired. This state requires drivers to take not only a vision test and a written exam about the state's rules of the road, but also a practical road test. You pass all of these, your expired license is stamped, and you'll get a new one in the mail within a week or two. This is an example of non-politicized licensure. But what if your state decided it wants to license drivers like it does healthcare workers? Licenses would not be final until the legislature approves it. Now, it just so happens that the Taxi Driver Association is worried that too many new drivers are working for Uber. So they've convinced the chairwoman of the Transportation Committee to reject your application. And coincidentally, her husband drives a cab. Your license dies in committee before it's even introduced into the legislature. And this is politicized licensure. This is how nurse practitioners, pharmacists, physician assistants, physical therapists, clinical psychologists, nurse anesthetists, midwives, and dental therapists have all been denied the opportunity to practice what they've been educated, trained, tested, and certified to do, even if they've successfully done it in other states for years with different licensing laws. In the non-politicized system, you are assumed competent until proven incompetent. In a politicized system, you are assumed incompetent until politicians who may know nothing about your profession decide you are competent, and they may have their own agenda. But you ask, isn't there a world of difference between a driver's license and a license to practice medicine? Patients can't hope to understand the complexities of disease. They must be protected because of an asymmetry in knowledge between doctors and patients, especially if there's a life-saving emergency. Physicians have to make critical moment-by-moment choices, and patients' lives hang in the balance. The state has a duty to protect them. Not only that, it takes physicians many more years of training than any other healthcare worker to be trained. So these are the arguments that justify the current system. Let me explain why I think they missed the target. Longer physician training includes 4 years of college, and some of that time may have been spent at a football game or a frat party. It takes a year or two longer for, excuse me, there's a lot of background noise I'm hearing. I don't know what that is, but longer physician training includes 4 years of college, and some of that time may have been spent at football games and frat parties. It takes a year or two longer for American physicians to finish their training as their counterparts in other advanced countries. There is no market incentive to shorten the training process, quite the opposite. And with increased specialization, training times are getting even longer. The medical license is granted primarily on the basis of having graduated from an accredited medical school and 1 year of accredited postgraduate training. There's no practical exam. Even stranger, licenses are granted before the overwhelming majority of modern physicians even complete their specialty training. So the state never tests them for the skills they use on a daily basis for the rest of their careers. When your license expires, it is reissued, providing you haven't run afoul of the law. You answer a few online questions about whether you drink too much or use drugs, and then you pay a hefty fee. You are not tested for competence. Surgeons aren't even tested for eyesight. A medical license is undifferentiated. It's indefinite. You are legally entitled to practice medicine under a very broad definition and a very vague standard of care. This is unlike potential competitors who have to demonstrate specific skills and remain within a specified scope of practice. The medical license is a vestige of the medieval guild charter, and the state will enforce your monopoly. Now, this is unlike highly trained professionals outside of healthcare who also have critical skills, who don't have licenses that protect them from competition. Take airline pilots, for example. Like automobile drivers, pilots have to learn the basics, an understanding of aeronautics and the rules of flight. They take a written exam, a specified time of supervised training, a physical exam, including eyesight, and practical flight exams. They too have to make critical decisions, moment by moment. The lives of hundreds of people may hang in the balance, especially in an emergency. There is a huge asymmetry in knowledge between the customer and coach and the pilot in the cockpit. In the airline industry, the market makes corrections that politicians only argue about in the healthcare industry. Look, we talk about there being too many medical specialists and not enough family doctors. We worry about a looming shortage of physicians. So why aren't there too many pilots flying 737s and not enough flying Learjets? Why aren't there a lot of think tank experts attending an air travel economic summit today proposing bipartisan solutions for air travel inequities? Unlike medical schools, just about anyone who can read, write, and has decent eyesight can matriculate into a flight school, no guarantee of graduation. The schools do not have to be accredited by the FAA. Aeronautical training is both stacked and modular. After being certified to fly single-engine aircraft in clear weather, one can elect training to be certified by instruments or multi-engine aircraft, and this can be done in either order. Flying commercial takes more training and testing. Flying for airlines, even more. One can skip some certifications and go direct to the airlines, or wait years before you try, or never try. Military experience counts. A 737 pilot would be laughed out of the sky if he claimed that a competitor should be banned because it took him longer to achieve the same skill she achieved in a shorter period of time. Pilot certification is granted on the basis of demonstrating transparent standards of knowledge and proficiency. Pilot licensure is non-politicized. Can you imagine how a politicized automobile driver's licensing system would have retarded the introduction of Uber? If 737 pilots could lobby politicians to limit how many pilots were trained to fly their aircraft, we'd soon be paying a lot more to fly in one. So now you can understand why the 21st century needs a reformation in medical licensure. And let's take one example. This afternoon, we will discuss telemedicine. This is a promising technology that could have developed much more quickly than it has today if licensure was depoliticized. In 2004, in a proof of concept endeavor, a surgeon in New York robotically and safely removed the gallbladder from a patient in France over the internet. Last night, radiologists in Australia were reading the x-rays of American patients in emergency rooms while their American counterparts were sleeping. There is no reason why patients in the most remote village of a third world country could not consult with the world's leading experts in their disease. 45 years ago, when I was practicing in Flagstaff, Arizona, many of my Native American patients had to travel hundreds of miles over poor roads to see me. Before my retirement 5 years ago, I was at the Mayo Clinic. Patients traveled thousands of miles by air to see me. And I estimate that I could have saved at least 40% of those patients the trip with a telemetric consultation. The technology for me to do that was available in 2015, but we could not take advantage of it because of licensing and compensation restrictions. And I think the great majority of medical encounters could be done with patients in their own home in the future. And just like taxis and Uber in the rain, the waiting time for service will be drastically reduced from weeks to minutes. There is no medical or technological reason for this not to occur. Compensation barriers are beginning to come down thanks to a pandemic. The barriers from licensure will be more recalcitrant. So even now, though, entrepreneurs are waiting to deliver innovative healthcare across state and international boundaries. Emergencies have a way of exposing what is real and what is bogus. During World War II, medical programs were reduced. Immediately after Hurricane Katrina, Louisiana temporarily relaxed its scope of practice regulations so that qualified nurse practitioners could provide their expertise. COVID-19 is once again proving that licensure protects special interests from competition more than the public from dangerous practitioners. I have a close friend, a nurse practitioner I worked with on the Navajo reservation years ago. She's delivered babies in the most primitive conditions, far from specialists. She saved patients with heart attacks in homes without electricity or running water. And now, she is now leading a pandemic response team across northern Arizona. She trains pharmacy students, medical students, nurse practitioner students, and PA students, physician assistant students, all in the same classroom. But if she lived in California instead of Arizona, she would not be able to independently practice unless a physician, possibly one less qualified than she, supervised her. She and I have testified in front of the Arizona legislature to reform scope of practice laws, and neither of us are holding our breath. When this emergency is over, the status quo will probably be reestablished. In my chapter in Purple Solutions, I discussed the possibility of creating an alternative pathway for licensing healthcare workers. This advocates removing exclusivity from medical practice acts and permitting any healthcare provider certified by a state-approved, accredited professional board to practice at the top of their license. Model legislation for this approach was written by Byron Schlomack, and you may download it from the Goldwater Institute's website. Now, there's obvious kinks to be worked out, but they are mostly regulatory and political in nature. Silly things like figuring out how to let patients telemetrically consult healthcare providers across imaginary state lines. Removing exclusivity from medical licensure will be like removing a dam in a river. The downstream effects will be astounding. You cannot imagine how the training of healthcare workers will evolve from the ground up were that to be done. A flood of creative innovation will sweep away the silos that have constrained medical thinking and healthcare delivery for centuries. It will provide opportunities for previously excluded and marginalized groups from the healthcare industry. It will eliminate foolish, costly, and polarizing turf battles between warring health professions. It will empower state governments to more wisely utilize their resources to do the one thing they can do better than the private sector, and that is to sanction and eliminate the small minority of incompetent, unethical, or dishonest practitioners, and maybe plan for pandemics. Now, our proposal isn't perfect, and I am sure there are other ways to accomplish reform, but it does have the virtue of being politically feasible. In Arizona, increased scope of practice legislation has had bipartisan support if it can get through committee. In our federal system, if one state were to depoliticize licensures, others could follow. Perhaps we could get away with what Uber did to the politically protected taxi monopoly. We could define commercial transactions for medical care delivered over mobile devices between individual patients and providers of healthcare as sharing, and just ignore licensing the way Uber ignored taxi medallions.
We should probably end on that note.
Just about done.
Yeah.
Or maybe in some future utopia, we could abolish licensure altogether and protect patients by what are the truly effective determinants of medical competence, such as hospital credentialing, insurance reimbursement panels, malpractice considerations, branding, specialty certification, and yes, patient recommendations. That way, our healthcare needs can be provided similar to even more human necessities like food. Jefferson is supposed to have said, "Were washing to tell us when to sow and when to reap, we would soon want bread." A century ago, about the same time our medical licensing laws were being enacted in the United States, Russia experimented with a single-payer government-run program for food. Millions died of famine. We should work together and think of a better way for healthcare. And thank you.
Thank you, Dr. Feldstein. That's great. Unfortunately, I don't think we have time for questions. There was one question about many speakers talking about depoliticizing healthcare, but that seems impossible. How are we going to kind of move beyond that? We don't really have time for the question per se, but I just want to say that I sort of think you answered that, is we're not necessarily asking the government or people to vote any particular way. We're just looking to empower providers, people that want to be physicians and consumers in the way that Uber did. But this is a big topic, and maybe start by reading Dr. Feldstein's chapter. And I should say that in higher education, this whole idea of competency-based education is becoming very popular, which is to say, maybe you don't need to take a year of these classes if you've demonstrated that you have this knowledge already. And so that sort of touches on it. And I wish we had more time, Dr. Feldstein, but thank you. So.